everybody. Hi. So my name is Katie Bucher. I'm the Community Relations Specialist here at Providence Little Company Mary Medical Center. And on behalf of Marketing and Community Relations, I just want to welcome you to this evening's presentation. The first thing I'd like to do is direct your attention to the packet on each of your seats. Everything within this packet is for you to keep, with the exception of the evaluation form and the question card. We'll be collecting the evaluation forms from you at the end of the night before you leave. So if everybody could do me a favor and pull out the evaluation form. It looks like this. Has little boxes on it. So I just want to go over the boxes with you really quick. The first box refers to our mailing list. So everybody should have received an In Good Company magazine this evening. We mail this out 3 times a year. So if you'd like to receive this magazine, go ahead and check that box, put down your information, and we'll make sure that you get put on our mailing list. And then the second box is for requesting a consultation. If after this evening's presentation you would like an appointment with Dr. Ascari, Dr. Morse-Rowe, or Dr. Milano, go ahead and check that box, provide us with your information, and we'll have somebody from our Health Resource Center contact you to set up an appointment. And then I just want to go over a couple of housekeeping items with you. We won't be taking a break this evening, so feel free to get up if you need to, move around. There's refreshments in the back. Restrooms are just right outside these doors to your left. And then we won't be opening it up for questions from the floor. Everybody has a question card in their folder. So while the presentations are going on, go ahead and write your questions down. And at the conclusion of all 3 presentations, we'll collect those, and we should have plenty of time to answer all your questions. And then finally, if you could just please silence your cell phones. So it's my pleasure to introduce our moderator for this evening. Jenny Gabelsberg, holds a doctorate in physical therapy and has been practicing physical therapist for the past 23 years. She quickly found her passion in treating women and men with pelvic health concerns and has been specializing in this for the past 20 years. She opened her private practice, Women's Advantage, Men's Optimal Health Physical Therapy, in 2001 in Torrance. She has started as a one-woman show, and the practice has now grown to 13 staff members. She also is on the faculty of the Herman Wallace Pelvic Rehab Institute, where she lectures nationwide on pelvic health and obstetric conditions. She's very active in both physical therapy and Urogyne national associations, but also loves to give small community talks as well. So please help me in welcoming Jenny.
Gabelsberg is a tough one. I married into that one. I am so happy to see so many people here for this important, very impactful topic of pelvic health. When I was in physical therapy school, I didn't even know pelvic health was a specialty that physical therapists trained in, and I bet most of you probably didn't either. So I started my practice as a general orthopedic physical therapist for the first 3 years, and then a urologist approached the clinic I worked for, and he asked if anybody knew how to treat urinary incontinence with biofeedback. And I was the only one that was willing to go to the class to learn about it. And the only thing I really knew about incontinence was I really thought it was a nursing home problem. I didn't realize that it happened to community-dwelling adults. And so I went to this course, and there were about 40 physical therapists there. And, we think of physical therapists as being pretty fit, athletic type of people. Everyone was under the age of 40, and half of them were there to learn how to treat themselves. And I thought, what is this? I didn't even know this existed. So I started specializing in pelvic health. I found my passion where I really needed to be. I opened my own private practice a few years later, and so that's been around the last 17 years in the South Bay, and obviously has grown quite a bit. There's a huge need for pelvic health in the South Bay. So I have really enjoyed being able to work with the 3 physicians you're going to hear speaking tonight, and finding people that are equally passionate about pelvic health as I am. So I'm sure you're going to enjoy this evening. I'm going to introduce first Dr. Reza Ascari. Dr. Ascari is a native to the South Bay. He went to University of California, Santa Barbara, and studied medicine at the Saba University in the Caribbean before completing his residency training in OBGYN at Lincoln Medical Center in the Bronx, New York. During his 4 years in residency, he developed a solid interest in minimally invasive surgery and spent his fellowship training at the University of Buffalo State University of New York. He received his board certification in OBGYN in 2013. He's had a long-standing interest in urological issues and pelvic floor disorders because his own father is a longtime South Bay urologist, and further developed in the field of pelvic floor disorders during his time in fellowship. So he specializes in urogynecology and minimally invasive surgery. Following his fellowship, he practiced in Seattle and is proud for developing and implementing the robotic surgical program for Pacific Medical Centers before returning to academic medicine and training fellows in the American Association for Gynecological Laparoscopic Fellowship located in Las Vegas, Nevada. He came to join Providence in 2016. So, as well as being active in the medical community, he's married, a devoted husband, and a father to an 8-month-old son, an avid dog lover, loves to play tennis, and just being an average Southern California gentleman spending time at home. All right, so please join me in welcoming Dr. Ascari.
Hello. Hi. Okay, great. I love it. The coffee and the water. Is this an overactive bladder lecture, or is this on Prolapse? Okay, there's bathrooms to your left. Well, thank you everyone for coming. My name is Reza Ascari, and it's really happy to be back here. I love working for the ministry as well, so if you do have any questions, happy to answer them at the end. I'll try to do my best. So today we're all, by the way, Jenny's fantastic. Once I found her, my patients are very happy, so I appreciate all you do. And Dr. Marshall, Dr. Milano, excellent physicians indeed. So my portion of the talk today is actually, I'm going to be speaking about pelvic health, some innovations, and I'm going to kind of focus on the surgical aspect and robotic surgery. I'm not saying it's the only way to do it, it's just my focus today. I think there's many different options toward how to reconstruct your pelvis or your pelvic needs. It's just my focus is on this today. It's just finding the right physician and the right approach and what the successful outcome will be for a person's particular problems at that time, okay? But I'm just focusing on my topic today, but it's very broad. So, pelvic health lecture. Okay, innovative treatment options for pelvic organ prolapse. That's me. So, I'm going to call it POP, pelvic organ prolapse. It basically means a condition in which our pelvic organs, which means the bladder, the uterus, or the rectum, fall into the vaginal wall. And in some patients, either bulge within where you feel it or bulge outside the vagina. It's kind of like a herniation. Is everyone familiar with a hernia? Like how a hernia is, like how it kind of comes out from the stomach? It's the same thing. And basically it's a weakness of the muscles and the connective tissues in the pelvis. 50% of females are affected by this, and about 20% of those have significant symptoms where they eventually end up coming and talk to their physician about it. Unfortunately, about half of these women, though, come seek medical help despite a significant impact on their quality of life. What I find is because they're kind of embarrassed to talk about it, but now what I'm seeing is a lot more people are speaking about it because there's a lot more awareness about it from talks like this, see ads on TV, in the magazines. So when we treat pelvic organ prolapse, and from a surgical aspect, it's one of the most common gynecologic surgeries performed. It's been done for many, many years. There's about 500,000 procedures performed annually, 1 billion spent yearly on surgery alone. There's an 11% lifetime risk of a surgery by 80 years old, and up to 30% will have greater than one surgery because there's a high failure rate of current procedures. I just want to put an asterisk that that's why it's really important for you to see the right provider for these, because not all providers do the surgery the same way. And I think from all of our backgrounds, I think we'd agree the way we suspend and the way we treat pelvic organ prolapse will be different from a lot of the general community doctors in town. So this is a slide. Sorry for the blurriness. I had to make it a little bit larger, but you see the surgery as it increases with age. And that's just a graph showing as you get older, you're more likely to have surgical management done. So people more than age 60 is going to increase by 72%. Women greater than 60 are more likely to seek care than their younger counterparts. And that's generally true. Demand for care of the service has grown, and we see that because there's now fellowships for this, particularly pelvic reconstructive medicine. And what are your risk factors? So I think this is what we're looking at. One is your postmenopausal state, which means your loss of estrogen. Your tissue has weakened. Another thing is repetitive pressure on the pelvis, constipation, asthmatics, people with COPD, obesity. When you have a large belly or you're putting pressure from the belly down to the vaginal cavity, you're going to start weakening the tissue, you're going to start getting a prolapse. Prior pelvic surgery, such as a hysterectomy, a lot of times the ligaments aren't resuspended or the ligaments just get weaker. Also, we see it a lot commonly in Caucasian females. It's due to collagen. Collagen is a little bit weaker than olive skin, Mediterranean toned African American females. So what are your symptoms? Well, there's a lot of different symptoms. A lot of times someone's going to feel pressure. A lot of times what I hear is someone's like, I was in the shower or I was gardening and I felt something and all of a sudden I saw something coming outside. What is that? And everyone always thinks it's their bladder. So, sometimes it starts with a urination complaint. I have difficulty emptying my bladder. I'm really straining and it's really hard for it to come out and I feel like I got to keep going. Inconsistent urinary stream. Sometimes the stool gets trapped in the rectum. The need to place a finger in the vagina to be able to empty their bladder or their stool from the bowel. Vaginal irritation, a lower backache, recurrent bladder infections, those commonly things that I hear about. So there's not just one prolapse. There's many different kinds. But compartmentally, the way I want you to envision is like this. Let's say and here I have these fancy words, anterior wall, systole, posterior wall, rectile. Forget everything I wrote here. If you look at, let's say this screen, let's say this is the back of the vagina, okay? Let's say when I do an exam, I'm coming this way, okay? Let's say this ceiling is what the top of the vagina and the bottoms, the floor is the bottom, right? So above the ceiling is the bladder, right? Behind this is the uterus. Below here is your rectum. So basically, anterior wall, the top is the cystocele, the bladder drops, okay? Posterior wall, the rectocele, right? The rectus drops, right? It's all bulging. The apical is the back. Interocele is when there's a weakness where the bowel's coming out. But long story short, the main three ones are cystocele, rectocele, and interocele. And I would think you'd agree most of the time it's not just an isolated defect. It's going to be more than one, okay? Generally, they're going to come one or the other. So a cystocele will usually come. You're always going to see like an apical prolapse for the most part with one of them coming down. And usually I think we're pretty good at identifying multiple compartments. So I was happy to find this slide. Basically, this is going to show what I was just explaining. Like we're looking at the vaginal tissue. The urethra is up there where your urine comes out, okay? So this right here is someone having no cystocele, no bladder is dropping, okay? Cystocele means the bladder. This one here, you see how it's coming out a little bit? That's the bladder dropping. And I'm not getting into the semantics of the terminology we use, okay? I'm just going to keep it very simple so you can kind of grasp what we're talking about. This over here is a grade 2. Now they're grading it, but it's coming down even more. And this is the grade 3. This is where it's kind of coming out of the vaginal area. There's something called a grade 4 where it actually really comes out, okay? But that's how we look at a cystocele. Believe it or not, I spent a lot of time on this presentation. So, and you'll see after this next slide why I just said that. So normal female pelvic anatomy. Okay, let me just explain this because it's kind of hard to, even I have a hard time looking at this. This is your vaginal area. So if I'm doing an exam, it's this way. That's your rectum. You pass stool from here. That's your bladder. So this is just demonstrating a rectocele. See how it kind of bulges here? And you see the bulge there? These are your vaginal cavity, your bulge here. But I didn't like that picture, so I was very smart. I reversed the previous picture, okay? I went to the Caribbean, okay? This is the best I could do. Okay, so we'll start from here this way, okay? So let's say this is your rectum now. No rectocele. A little bit of prolapse now, right? You seen that? The rectocele's coming out. A little bit more. And even more. All right? So cystocele, rectocele. You get it? Okay, good. We're not going to get into apical prolapse, okay? But I'm going to move on to the anatomy of pelvic support. This is very brief. Basically, your pelvis is, there's a bony pelvic framework, like when you put up a house, right? There's a frame. Fascia is, how would you describe fascia? Fascia is your very tough tissue layer. It's like your foundation of the house. Okay, it's a very tough tissue layer. Then you have your muscles, your levator ani muscles. These are muscles. And believe it or not, this is where physical therapy really helps us, because a lot of times when you're seeing a physical therapist, they're recoordinating the way your muscles work. And I have no idea how they do that. Okay, so she's the pro. And fourth, there's the collagenous connective tissue that attaches the pelvic sidewalls. Remember I was saying, people that are lighter skin, they kind of have weaker tissue versus olive skin, darker skin people. So this is where we'll see a lot of the prolapse, where we'll see some of the defects like in a perivaginal repair, or perivaginal defect. So how do we examine? So if you come to our office, typically we're going to put you on the table, okay? We're going to do a pelvic exam. A lot of times I'm going to have you stand as well. I'll get on my knee, and we'll do an exam as well, okay? I'll have you cough, see how your urethra moves. Sometimes I'll have you cough, and I'll see how much your bladder, your rectum comes out. We'll do a rectal vaginal exam. On the vaginal area, I'll check right here, the perineal body. I'll check the mucosa, okay? And then there's some procedures I can do to check for how your urination symptoms are going. Pelvic organ prolapse, which means the defect of your pelvic anatomy, is not necessarily related to incontinence. They're not one and the same. They can be related, or they can be individual issues, okay? But I check them together for the most part. Good so far? I'm not speaking too fast, right? I'm known to speak very fast. Okay, all right. So, treatment options for pelvic organ prolapse. Now remember, I said I'm going to focus on surgery tonight and robotic surgery. But there's many good options, and I always recommend being conservative. So the first one is non-surgical. A lot of times I'll have patients come in, they'll be like, hey, I have this. I'll explain it to them, like, okay, thanks. And I'm like, you're fine. Nothing needs to be done. Because it's not bothering you. I personally don't subscribe to the fact if it's not bothering you, you don't have to do anything about it. Because I don't save lives. I just treat symptoms. That's what I tell patients, for the most part. So, non-surgical. Then there's issues. A lot of times it's more with if they have incontinence issues, overactive bladder issues, and you've stopped drinking the coffee and you're not drinking bottles of water and whatnot. Then what we do is we send you to Jenny. Okay? And so that's where we do physical therapy. I'm a big believer in it. Okay? I think it works very well. Sometimes I have patients have time constraints that can't do it, but I call it personal training of the pelvic muscles of the bladder, and if your insurance covers it, I definitely think you should do it. And then they'll ask me, how long should I go for? I'm like, as long as Jenny will keep you. Go for it, okay? Because usually after 3 months, you'll kind of know, right? About 6 weeks to 12 weeks, you'll kind of know if it's working for you or not. And nothing's ever 100%. If it doesn't work, you come back, and then we move on. For prolapse now, there's pessary. Also for incontinence, you can do pessary. Now, pessary is what? Pessary is, I'm sorry, I forgot to bring my pessary kit tonight. You guys don't have anyone in your pocket, right? Okay, sorry. I'm a urologist and urogynecologist. I have to check. You never know. It could be a keychain or something. Okay, so basically what it is a pessary is, think of a rubber donut. Okay, I'm just going to use the most simple one. A rubber donut, and they have different sizes. And essentially what we do is we place it inside, and it holds everything back up. There's different pessaries, right? There's different, and we can fit you for different ones. There's a cube. There's so many different kinds, but basically just pushes everything back up. I heard in the South, when my friend was training at Duke, he found someone had a potato, and they had left it in there for a while, so I don't want to get into that. But basically it's placing something to hold everything up. Now there's surgery. Now there's many good surgeries. There's vaginal surgery. There's open surgery, okay? Now colporrhaphy means when we fix the defect, okay? Purely just fix like a facelift. And that's really what we're doing. We're doing a facelift of the pelvic tissue. The example I give is of the neck. If you look at someone who has a saggy neck and they go to their plastic surgeon, what do? They tighten the neck, right? And that's what a colporophy is. Now, when I add this word sacrospinous fixation, there's also uterosacral. Those are when you attach to the ligaments. And I think that's where we come in, where we will not only do the facelift, where we tighten the tissue, we attach it to the ligaments right here. And that's why you usually get more long-standing, long-term benefit from these procedures. Because there's still always failure because of gravity. Okay, because remember, we're always fighting against gravity here. Then there's the mesh, which is the implant. Okay, a lot of us we do meshes for slings. Vaginally, I kind of avoid the synthetic meshes myself personally, but they do work. But there's some side effects associated with them. Then there's a sacrocolpopexy, which is the mesh, as opposed to down below, where it's inside. Okay, and that's really what I'm going to focus on tonight. And that can be done either open approach, laparoscopic, which is small incisions, and you're using the laparoscopic instrument, or robotic, which is laparoscopy with a little bit more technology. So non-surgical treatment, behavioral changes, number one. I mean, you hate this. You come to the doctor's trying to be nice, and then he's like, well, you could lose some weight, okay? And you look at him, you're like, doctor, I'm 85 years old, and I've been trying to lose weight for like 80 years. And you're like, well, yeah, it's the first line approach, okay? But here's the thing. That always helps. A 10% loss will always help with your bladder symptoms, not necessarily your prolapse, okay? Avoid heavy lifting, okay? That's my big one. When you go to Costco or the grocery store, you see a strapping young person over there, or whoever it is, you have them lift it up, okay? You have the Arrowhead water or whatever, have them lift it up, okay? Don't do that. Correcting a chronic cough, quitting smoking, preventing constipation. Now that's weird, right? Because how do you prevent constipation? By drinking a lot of water, right? Or coffee, right? So it's kind of pelvic floor exercises, Kegels. Again, physical therapy, fancy Kegels, best way to do it. You can't reverse prolapse, but you can do actually physical therapy that can help you alleviate the sensation. And vaginal pessary, okay? And vaginal pessary is the most common non-surgical approach for prolapse. So this says vaginal pessary must be specially fitted. We remove periodic cleanings. You can do it yourself. We can do it for you. Sometimes there can be discharge and erosions. It's very favorable. A new study came out when I was doing my board research. There's about, within 6 months, most people know whether they like it or not. A lot of people discontinue it, but a lot of people will proceed with it. But I find that 6 months is a magic number. So remember I talked about the plastic surgery. So this is called the colporophy plication. Long story short, I'm just going to summarize this. Basically, you see how it says there's a 10 to 70% failure rate, 30% reoperation rate. Well, if someone's just fixing this tissue like this and not attaching it to ligaments to support it, you're going to see that failure. But now this is using sacrospinous ligament fixation, but a lot of us like doing uterosacral ligament fixations, high uterosacrals and whatnot, or sacral. So when you attach to a ligament, especially a strong ligament, you're going to see a higher, less reoperation rate, higher benefit. Okay. Now, this is talking about sacrospinous ligament fixation, traditionally done vaginally. Traditionally, it was done only on one side. The big issue with that is it would deviate the vaginal tissue to one side. A lot of us now, including myself, are doing it on both sides, so it keeps the tissue in its natural anatomic plane. Okay. I don't think it's technically challenging. I don't know. Do you guys think it's technically challenging? No, it's pretty straightforward now with what they have. But that's one of the approaches. So this is the mesh augmentation. It's probably the one you read about where like the lawyers are talking about. Yeah, this is to lift up the vaginal tissue. It was nice, a lot of doctors that it was nice when it first came out because it did it. I mean, it held everything back up. It held it up great. The issue was a side effect profile. It could cause pain, erosions. I mean, if you're a smoker, it's bad news bears. If you're sexually active, I mean, that's an ouchie right there. But it was nice to perform. People still do it. It's indicated for the right person. It does work. Now, sacrocolpopexy. Now, here's what I'm going to talk about. Basically, this is what we call the gold standard. In medicine, when you say gold standard, that means that's the standard by which everything else is measured by. This was done many years ago. It was done abdominally, okay? So the old, when I say, I learned this in Buffalo, someone called it the cut and gut. I remember we were doing a robotic case one time, and the lady was like, nah, I'd rather just get cut and gut. And I was like, okay. And so, so sacrocolpopexy, it's using a graft to suspend the vaginal tissue from inside. It works very well. But the reason why vaginal approach came about toward, with the vaginal mesh and graft, who wants to get a big incision this way or this way, have a long, painful recovery when you can do the same thing from down below? But what happened, but there are benefits to this. It maintains anatomical position, low reoccurrence rate, okay? There are failures in everything, but very low rates of failure on this, okay? But again, big incision. But now what happened? We can do it with small incisions, keyhole incisions, okay? Laparoscopically or robotically. So I'm gonna skip over this slide. Basically it says open, it's very durable, it works very well, and we're gonna go into robotic. So basically, sorry, I had a video tonight for y'all to show you how the procedure is done, because I always forget how people always really get enamored by surgery and the robot and whatnot. We had to remove it because I didn't realize a lot of you probably get queasy because it was actually an actual surgery. And so I apologize. I'll have a cartoon next time or something, or I'll have my son draw it or something. But here's the thing. There's a system out there called the Da Vinci surgical system. A lot of people will try to sell you it's the latest and greatest thing. It's not. But what it does is it's a good modality in the hands of the right person if you're the right candidate. If you want a procedure like a sacrocolpopexy, if you're indicated for it, that can be maximally non-invasive. It can be an open procedure. The robot will allow you to do it minimally. So you'll recover, as any robotic procedure, quickly over a shorter amount of time with the same results as having a great procedure like a sacrocolpopexy. Why? Because basically it has high definition 3D visualization, endo-wrist instruments. We are doing the surgery ourselves, okay? There's a lot of them in the US. I think there's more than 800, but it is very expensive. So this talks about the surgeon benefits. Basically, if you look at my hand when I do surgery, as steady as it is, no, I'm kidding. As steady as my hand is, the robot is much more steadier, okay? You can see much better. You can go into spaces a lot easier, and you can facilitate a more technically difficult surgery. Initially, they would always say do a very difficult surgery. If you're going to use the robot, I don't agree with that. Actually, you should be proficient at it and then pick the right person to have it done. So it actually has a longer learning curve. It's comfortable for us to sit down, but the patients, they do really well, especially in a case like a sacrocolpopexy. They do very well. I'm going to skip over this slide. This is going to go against why a laparoscopy, the traditional approach, is no good. And this is where I was going to have my video, okay? But here's what I'm going to show you right now. I actually have another video for you. Let's go right here. I got this off of YouTube. This is your Da Vinci, and that's a grape. As you can see, they're making their incision. So this is the doctor on the robotic console. The robot is another piece of equipment. As you see, there's 3 arms, 1, 2, 3, and the camera. So Providence actually has the Da Vinci Xi now, which is the latest one. works very well. General surgery now has a really great time with it. And that is just a video promoting the robot. Okay, let's see. Okay, so as you can tell, state-of-the-art, minimally invasive surgery that can correct your vaginal vault prolapse or uterine prolapse by resupporting the vagina to the sacrum, which is a ligament that's on your back. I'd say over here.
Robots performing surgery. It seems a little unnerving, doesn't it? But there is arguably something, dare I say, adorable about this little bot
I thought it was the
stitching
prayer.
a grape back together. Take a
I thought it was the prayer. I was like, it doesn't sound like that ever. Okay. Okay. So, in summary, using the gold standard for this particular procedure, it's really a benefit for this particular procedure. Shorter hospital stay, less blood loss, less need for transfusions, faster recovery, quicker return to activities. I vouch for that. Results, this was the New England Journal of Medicine. There was 30 consecutive patients with high-grade apical prolapse. This was out of Cleveland Clinic. What they found was with the sacral colplexy, there was greatly reduced morbidity. Patients left the hospital in 1 day as opposed to 2 to 5 days. Durability results equal long-term results of open procedure. Low complication rate, high patient satisfaction. There's great potential in this procedure. When we do prolapse surgery, a lot of times you may have some kinking of the urethra, may involve incontinence, right? Wetness, where you're involuntary wetting by laugh, cough, or sneeze. A lot of us, we will correct at the same time of procedure because up to 40% of patients will have stress incontinence once we repair the prolapse. I typically do repair at the same time. As opposed to if you don't, I fix your prolapse and then you have a stress incontinence, you have to come back for surgery again. So in conclusion, and I want to thank you for your time, pelvic organ prolapse, the demand for treatment's going up, especially with the ages. Treatment options include observation, pessary, or surgery. Colporrhaphy is minimally invasive, but remember, if you do it, and you always do it with a ligament suspension, right? Everyone's going to find their doctor, but okay, you're going to do a colporrhaphy, but are you doing that sacrospinous ligament? You're going to just make sure you see the right surgeon, okay? Mesh vaginal procedures may decrease this risk, but the data is showing that it has a high complication rate. Sacral colplexy, laparoscopically or Da Vinci-wise. That's the way it should be done. And this is just, robotic surgery may combine the best of both worlds. All I'm saying is this, vaginal surgery is the true minimally invasive approach. I love vaginal surgery, although, I train a robot and I do a lot of vaginal surgery. But for each patient here, when it comes to pelvic organ prolapse, you all are different, okay? So you have to find first a physician you trust, then you have to understand what they're telling you about your body, because it's your body, and third, what the right approach is for you. And also, I'll tell you, one prolapse is not gonna be treated the same way. You may see Dr. A, Dr. B, and Dr. C, and they might give you 3 different approaches. None of them are wrong. It's just what, in that hands of that surgeon, what they feel is the best outcome for you. And that's really the best advice I give you in terms of, falling forward if you have a journey in pelvic organ prolapse. But thank you for your time. At the end of tonight, I'm happy to answer your questions, but thank you for being here. Thank you. Turn this off.
All right, thank you, Dr. Ascari. So next up, we're going to hear from Dr. Erin Milano. She is a board-certified obstetrician and gynecologist who is fellowship trained in female pelvic medicine and reconstructive surgery. She has a passion for women's health, specifically pelvic floor disorders and bladder dysfunction. She completed her residency in OBGYN at UCLA. During that time, she had the opportunity to work with a team of physicians treating complex pelvic floor disorders and fistulas in Uganda. This inspired her to pursue a fellowship at UCLA in female pelvic medicine and reconstructive surgery, also known as urogynecology. Her primary interests include urinary incontinence, pelvic organ prolapse, overactive bladder, fibroids, pelvic pain, minimally invasive surgery, fistulas, and menopause care. She recently moved to the South Bay and now practices here in Torrance. She is on staff at Providence, Little Company of Mary Torrance, UCLA, and Torrance Memorial. In her free time, she enjoys running, hiking, and chasing after her children. Please join me in welcoming Erin Milano.
Thank you. All right. Thank you, Jenny. So 2 things. First of all, I tend to speak very quickly anyway, and when I get nervous, it goes super speed. So please let me know if I'm going too fast. Just signal to slow down a little bit. So tonight, I hope to complement Dr. Ascari's lecture by talking instead about the position of everything, sort of the function of the bladder side, specifically urinary incontinence. And I also recognize it's not 2016, it's 2018. It was a typo late last night. So tonight we want to talk just a little bit about, and I'm going to kind of talk about it the way that I would talk to anybody, my friends, my family, about what I do, and about kind of the way I would evaluate it. So I'm bringing it down maybe a little bit more basic than what you guys are all familiar with, but just so that it kind of is all in the same area. So tonight I want to talk a little bit about what is urinary incontinence, and are there different types? And specifically, we're going to talk about management for stress incontinence and urge incontinence because they're the most common types, but there are different types. Talk a little bit about how common it is, and then what we do in the office. How do we evaluate for it? How do we try to determine what's going on? And then what are the treatment options? So urinary incontinence is an involuntary loss of urine. There are many different types. I thought this cartoon was kind of cute, but there's actually way more types than this that we define. Stress incontinence is when you cough, laugh, sneeze, some sort of exertional force, and leak urine. Your urge incontinence is when you have a desire to urinate and cannot make it to the bathroom in time. And these are very different, and the treatments of them are very different, but they oftentimes cross over, and many times people have a little bit of both. And so it's important to kind of delineate between them because the treatments may vary depending on which type. Overactive bladder can be associated with incontinence and is more commonly associated with urge. Functional just means you can't find a toilet. And there's like nowhere for the next 50 miles, and so there's no way to get there. Overflow is, I kind of liken this to a little bit like a watering can that's full. So if you have a full watering can and you're walking around and it sort of sloshes out, it's not that you are leaking because you're overactive necessarily, it's just your bladder's real full. And then transient usually means a particular situation, like you're sick, you have a cough, you only leak when you have the flu, otherwise you're doing fine. Oops. Oh, how do you go backwards? Oh, I'm going to go real fast, just like I talk. So it's common. 50% of adult women have incontinence. In 2007, they published a paper looking to see like how much does it actually cost in the United States, and so the direct cost at that time was $19.5 billion. So clearly, it is something that is a healthcare issue. And 6 to 10% of nursing home admissions, and we quote this a lot, but 6 to 10% are strictly due to urinary incontinence. Who gets it? So I thought this was interesting when this was published just a couple years ago. And when they did a survey of high school and college athletes asking about stress incontinence, 25% of them endorsed stress incontinence. When they looked at women after they deliver a baby, it's been quoted about 30%, it's probably more than that, but have transient incontinence after delivering a baby. Between women between ages like 40 and postmenopausal, more than half. And then in nursing homes, up to 75% of women have issues with urinary incontinence. So clearly it's a huge problem and it's a healthcare concern, but how does it actually affect us? So quality of life is a big deal. People will not go out and do certain things. They'll limit their activities. They'll say, I'm not going to Disneyland because I'm going to have to know where every bathroom is. The lines are too long. I just can't do it. There's some sexual dysfunction associated. People are either worried that they're going to have leakage or they're worried about other issues with the pelvic floor. Infections, so both urinary tract infections and sometimes also people get skin issues because of leakage. Sometimes the pads can be wet and other things, and it can lead to kind of chronic skin issues. And then interestingly enough, so in the group of patients that have urinary incontinence, especially the people that get up at night to urinate, you have more than a 2-fold increased risk of having a fall, which is a huge concern. So are we talking about it? Not really. Less than 50% of women actually really seek care for this issue. And the question is kind of why? And so when they've done surveys to look, some people are not bothered. So clearly if you're not bothered, there's no reason to seek care because you're not bothered by it. Some people are bothered, but their response will be, well, I don't want surgery. I don't want to take a medication. It's normal. I hear a lot of like, oh, I leak, but that's normal if I had a baby, so this is going to be normal. I'm too embarrassed to bring it up. And this is where, as healthcare providers, we are supposed to come into play. There was a statement that was issued by American College of OBGYN that says that all of us are supposed to screen for it. We're all supposed to ask all of our patients, do you have any issues with your bladder? Do you have any issues with your bowel? It's supposed to be part of your regular screening. And that's because we recognize that people are a little bit too reluctant sometimes to bring up things like this. The risk factors for it, and this goes a lot with Dr. Ascari, so some of the stuff is going to go hand in hand because pelvic floor disorders are really common to have a lot of symptoms that go together. So obviously pregnancy, childbirth, the type of childbirth, your age. So some women will have it, and then as menopause occurs, it tends to become more common again. Medications that you're on, obesity, family history, and then there's a huge category of other. There are a lot of other things that go into this. This is just really quickly to review the bladder because we're going to go into the specifics in a second. So really quickly, the bladder is meant to hold urine. When you want to go, it's meant to release it. When you don't want to go, it's meant to store it for you. That's the function of the bladder. When you have somebody with stress incontinence, what happens is that there's some sort of force from above, and the urethra, which is the muscle or the tube that the urine comes out, the urethra is not able to withstand it, or it has mobility, really, which causes the urine to leak. Urge incontinence is associated more with actually the bladder itself, and that there's some sort of nerve signal that's giving you an urge when you shouldn't need to necessarily have it, and the force is overcoming the urethra. So this is going to be really just a brief, when anybody comes to the office, and this goes very similar with what Dr. Ascari said, when anybody comes to the office and we do an evaluation, there's a few basic things we do to try to figure out what type of incontinence do you have and what exactly is going on. So a history and physical is key. A lot of it is symptom questions, like what is exactly bothering you and how much does it bother you? Because that's an important thing to get to the bottom of. We usually check to make sure that you don't have a urinary tract infection or some other thing that might be going on with the urine. That's a huge thing to figure out before we start a treatment plan. We want to see how well your bladder empties. So that goes back to that whole watering can scenario where somebody will say, I have to go to the bathroom every 5 minutes. And it's not because they have an overactive bladder. It's because they only urinate a small volume at a time, and their bladder is always full. So we always want to make sure you're emptying your bladder all of the way. You want to demonstrate incontinence, and this actually really only applies to people that are planning to have a surgical treatment for stress incontinence, but it may be something that you're asked to do, to like cough or sneeze to see if you have leakage, and also to see what your urethra is doing. You want to assess for neurologic function, so to make sure that that's intact. And then you also want to look at the same time for any other pelvic floor disorders. And I think Dr. Ascari already very nicely touched on what he does in the office and what we do to look for other pelvic floor issues. There may be more invasive testing. This is not for everybody. It's only reserved for certain situations. So there are other tests that we can do to look at the function of your bladder to get a better idea of how it's working. We want to know if, for example, if your problem's really unclear. So for people that say, listen, I leak urine and I have no idea it's happening, I'm leaking urine without any awareness, my pads are just wet, but I don't ever feel it coming out, it's not with cough or sneeze, that's a good candidate for trying to get a better handle on what's going on. If you have history of prior surgeries, and if we need it to assist us in treatment planning, these are all reasons to either do a functional test to your bladder or to take a look inside the bladder. And those are both things that can be done in the office, and it's just part of kind of a treatment planning. All right, so now we're going to talk a little bit about treatments. So for stress incontinence, this is by far and away the most common type of incontinence. It's a loss of urine, like I said, with cough, sneeze, laugh, jump. I can't go to trampoline parks anymore, things like that. And I thought this lady was kind of funny because it really has become a running joke that it's one of those where many people kind of laugh at the idea of when I say, oh, do you want to be able to, go to the gym and do kickboxing or do trampoline parks? And for whatever reason, trampoline parks are like the biggest joke. Nobody can do a trampoline park. So this lady I thought was kind of funny. This right here, the whole reason, this is kind of like the other slide, but the whole reason I put it up here, and it's like going to be too hard to see because it's kind of small, is that the thought is with stress incontinence is that there's damage right here to the pubourethral ligament, which is something that happens for various reasons, but it's what supports the urethra. And as soon as the urethra loses that support and has this extra mobility, it can lead to stress incontinence. It's not the only cause of stress incontinence, it's just the primary one. So the treatment options are kind of dependent a little bit on you and how much it bothers you and what you want to do. In general, and I think this is maybe because I'm married to an orthopedic surgeon, I always think about these as like knee injuries. And so it helps me kind of, put it into perspective. So you can do things for support. So if you hurt your knee, you could put a brace on it. So you can have some sort of support device. If you did something to your knee, you can go to physical therapy and try to do rehab. Or if you do something to your knee, you can go get surgery. And so those are kind of the main ways that I think about stress incontinence, or those are your three primary options. There are some other things that exist, and we'll talk about all of it. So for stress incontinence specifically, and this is a little bit different than some of the pelvic floor prolapse, but for stress incontinence specifically, there was a big study published in the New England Journal of Medicine that looked only at women that were considered by BMI overweight or obese. And in those individuals, if they lost 8% of their body weight, they decreased their symptoms by almost half. So very effective, the hardest treatment of all to do. So it's a good thing to do. It's a wonderful thing if you're able to, but it is a really hard thing to do. Other modifications, and this is only for stress incontinence, they may help, but they're probably not going to be where the money's at, but they can help, is avoiding bladder irritants, urinating on a schedule, making sure you're doing different fluid management, so not drinking when you're going to do right before you're about to do kickboxing and urinating right before you go and then going back. So kind of trying to manage it a little bit. There's insufficient data to say that this is going to be a great option, but it can help. So for intravaginal support devices, this is the pessary that Dr. Ascari was talking about. This one is specifically for incontinence. And the way I think about it is it's something that goes in the vagina. It has a little knob underneath it, almost like a little diamond ring. And it sits there and it supports the urethra. So that when you cough and sneeze, it has something to push against and a backboard against it. It is not intended to close off the urethra. You should still be able to urinate with it. And it's intended to make your life better, not worse. So when people look at me cross-eyed like, that sounds terrible, well then, not a good option for you. So it's intended to make things better. The problems with it are that it must be fit by an MD. So you have to go to the doctor's office. We have to find your size. It has to be comfortable. It shouldn't fall out when you're walking. It should stay in place nicely. All of those types of things. So you kind of have to find the right one. It has to be cleaned periodically. Yeah, it would be terrible. It wouldn't serve its purpose if it fell out while you're walking. So it has to be removed and cleaned periodically, which for some people it's really easy to do, and for other people it's a little bit more challenging. About 50 to 60% of people stick with it. So if you find one that fits, which first of all, about somewhere between 60 and 75% of people can be fit correctly, meaning it's comfortable, they're happy. Of that group, about 50 to 60% of them stick with it about a year. The other option, so this device came up with by Poise, who makes some of the urinary incontinence pads. They were like, well, listen, can we make this pessary way easier for people to use? So we're going to make a consumer-friendly product that you can buy over the counter, CVS, Rite Aid, Walgreens, wherever you go, and it's going to be super easy for the consumer. So we're going to have a sizing kit. You buy a sizing kit, you try on the sizes. You try on size 1. If you jump up and down and you're still leaking, try on size 2. If you don't leak, size 2. And so they have a study that was kind of sponsored and published by them that looks like excellent results. So more than a 70% improvement in 85% of women at 1 month. So looks great. There's a few little problems with this. Number one is it's disposable. You can only wear it for 8 hours at a time. I find that the group that likes it best are those that leak with a specific thing. Like, I'm going to a trampoline park. I'm going to leak there, but otherwise I'm pretty good. So they'll wear it for that, and then that will be it. For people that tell me, I leak when I laugh all day long. I can't time it. It's going to be a little harder for me to know when to put this in. I find that group doesn't like it as much. And also the cotton, it's not an absorbent cotton. It's a more smooth cotton, but it's still cotton. So it can be a little bit uncomfortable if the tissues are dry at all. So, and it also opens up kind of funny, like a little box. And so the little prongs can kind of get stuck. So again, it's not a bad option, and it's something you can absolutely try. It's super easy to try over the counter, but there are some kind of issues with it. So I just found this one, and I don't know if you've used this at all, the Uresta. Okay, so this is kind of new, and it looks like it's mainly in Canada, but you can order it online. I looked, it's $300. So you can order it and try it out, and it's like the hybrid version of the two. You buy a sizing kit very similarly, and it's made out of more of like a silicone material, the way the pessary is, and it's meant to be a little easier to put in and out. And their data looks basically the same as the pessary data, even though they worded it a little bit differently. They had 2/3 of women were successfully fit. Of those, 76% were using it at 1 year, which ends up going back down to about 50 to 60%. So it's about the same as the pessary, but it did seem to have a substantial improvement, and I think probably material-wise, it may be a little bit more comfortable. The next sort of line of treatment, so there's the brace, and then there's the idea of, well, can we just do some rehab and get it to improve? And this is where Women's Advantage and Jenny have been like instrumental, because they are a fantastic place to send patients. But pelvic floor physical therapy, if you're going to go there, please make sure that whoever you're seeing specializes in pelvic floor physical therapy, because there's a difference between doing some exercises for your core but not actually doing pelvic floor physical therapy and actually seeing a pelvic floor physical therapist. You can do them on your own. Let's see if I can go back. So everybody will say, well, how do I know I'm doing them right? I've done them like my entire life, 800 times a day, and nothing seems to happen. And so it's actually, this next slide, like more than 60% of people do them wrong or don't know how to do them. But what we try to tell people is try to practice in a time when you can be kind of quiet without having to do 800 other things, so you can focus on it. And the goal is to do somewhere between 10 to 20 at a time and to contract and hold as long as you can. The idea is you want to kind of pull up and not push out, which is actually one of the biggest problems, is that people end up pushing instead of pulling up. But you tell people to do it, try to do it, hold it as long as you can, and the physical therapist try to get you to do it for 10 seconds, which is like very hard to do. So I tell people, if you can do it for 2 seconds, start with that and then build on it. And to contract and hold and then relax, and then that's working on the strength. There's also some of the people that need to do like the quick ones to work on reflexes, which can be helpful. And then the way you use it, because if you just get your pelvic floor kind of strong, that's great, but the way you use it is when you're about to sneeze, you reflexively contract the pelvic floor so that you don't leak. But what if they don't work for me, because more than half of people don't know how to do them or are doing them incorrectly and think we're doing them right? And you kind of wish, it's not a muscle like your arm where if you contract it, you can see it, and you know that that's how you contract your arm. This one is not a muscle group you can see, so it's really hard to get the biofeedback from it. Pelvic floor physical therapists are very helpful for that. There's also a lot of devices that exist that help give you some sort of feedback. I would argue a little bit that maybe going to pelvic floor physical therapy where you can get the verbal cues first may be more helpful than immediately buying a device, because then, first of all, your insurance will cover it, and you can also kind of have a little bit of an open conversation. And then the devices may really help augment your ability to do these at home. So the success rate, it's actually way better than the pessary. So at 3 months, 75% of people are very satisfied with this. And these studies all come out of Europe, where a lot of people do pelvic floor physical therapy. It's kind of like the mainstay of care, as you start with that. At 12 months, though, and this is sort of like if you buy a gym membership and you're very excited to go at the very beginning of the year, by the time you get around to December, you realize you're not going anymore. It's the same idea. So it drops off to 50%, because while you're in the physical therapy and really doing the exercises, because you have somebody holding you accountable and it's exciting, as soon as you stop doing them, you're going to lose the benefit. So it drops down to about half. So you need to continue doing them. And then when you compare it to surgery, and this is not a plug for surgery, it's just more to talk about the differences in success, is that at 1 year, 85% of patients are satisfied with surgery. So just to quickly talk about what the surgical options are. There are different procedures. There's slings using mesh, slings using non-mesh, there are sutures, and there are injections into the urethra. And we'll talk about each one kind of briefly. The idea behind anything that goes under the urethra is that you're trying to restore the support of that original ligament I told you about that kind of is broken or stretched. You're trying to restore the support in a tension-free manner, so that when you cough and sneeze, it has something to kind of help support it again. It's not intended to close off the urethra. It's not intended to lift the urethra. It's there for support. So the reason I'm showing the mesh slings first is because they are actually considered the gold standard or the standard of care at this time. And we'll talk a little bit about the mesh mess that Dr. Ascari alluded to. But they are probably one of our most successful surgeries. And they can be done in two ways. They can either go behind the pubic bone, they can go through the obturator, but that's a different part on the pubic area, or they have ones now that don't go all the way through, which most of the time I'm personally doing the traditional mesh slings if I do them, but there's some data to support the single incision slings, which are the ones that don't make any holes on the outside. They work. So at 5-year follow-up, subjective improvement is about 80%. And at 9-year follow-up, it's between 60 to 75%. So subjectively, they have long-term data. And now they've been in the United States since 1997, and they were in Europe before then. So we now have more than 20-year data on safety and efficacy of these. There are complications, just like there are with any surgery that exists. And the one that I think people worry about the most are mesh complications, because that's where a lot of press has happened. The risk of a mesh complication with one of the mesh slings for urinary incontinence, so not placed transvaginally for prolapse, but for urinary incontinence, is about a 3 to 5% risk of a mesh complication, meaning like any number of things, but the one that most people associate it with is like the vaginal tissue opens up a little bit and you can see the mesh underneath it and it has to be removed. Not the whole sling, but that area, although there's many debates about that too. So the reason that this is a mesh is because if you Google mesh, and if you go home and you're like, oh, she said you should use mesh, you're going to find 800 lawsuits on mesh. Like, it's going to be like, did your doctor talk about mesh? We can sue them. Like, there's a lawsuit for you. So it's because, and it has everything to do with the fact that, there's more jury verdicts against it. I mean, it has a lot to do with the fact that there was an FDA health statement that came out in 2008 because there had been a lot of mesh placed transvaginally, like big pieces, and they had used the safety data from the sacrocolpopexy that Dr. Ascari was talking about and the mesh slings to get their devices approved, saying they must be safe, it's the same material, it's the same idea, so it's going to be safe. The problem was that there wasn't a lot of safety data that they did themselves, they were just using somebody else's information to get it approved. So unfortunately, the complication rate was a lot higher, it was almost 20%. And so when that complication data started coming in is when they started putting out the warning saying you shouldn't use this. But now, unfortunately, if you use the word mesh sling, immediately you're going to find all of this on the internet, and it takes a long conversation to try to explain the differences between them. And this really applies to the transvaginal prolapse mesh and not the sling mesh. But once this idea has sort of been planted, despite the fact that we would reiterate, this is a minimally invasive procedure. It's the best procedure we have. It's the standard of care. FDA has recognized it. We've all recognized it. We have more than 20 years of data. Even so, you're going to find people that are saying, like, forget it. I don't want anything artificial in me, and that's fine. So there are other options. You don't have to have that. So kind of the old became new again, and there's been a big trend in doing what we call fascial slings, so making a sling out of somebody's own tissue, and that can come from anywhere. And either the leg or usually the abdomen is where you get it. And you can actually fashion a little sling and make it. And that's what we used to do before we had mesh. And so it's more invasive because you have to find this piece of tissue. It takes a little bit longer to recover. I find it takes a lot longer for the bladder to sort of bounce back from the surgery. It eventually works great, but it takes a long time for your bladder to get back to where it was. But there is no artificial material. So people really like that idea. And there's definitely a role for this in certain individuals, but there's also, it's become a lot more popular as well. So I'm going to briefly mention this because we don't do this as much anymore, but you can also use suture to kind of help support the tissue on either side of the urethra to lift it up. That can be done minimally invasive, so you don't have to have an open incision. You can actually do it laparoscopically, and it helps to support the urethra. Which surgery works the best? So interestingly enough, long-term, the mesh and the fascia slings, when they were compared head-to-head, actually have a similar, not exactly the same, mesh seems to be better, but a similar efficacy. And both of them are more durable than using suture. So sling in general, so providing something underneath the urethra seems to be a better surgery overall. There is something called urethral bulking, which I lump into this category because it's us doing something to you. And what it does is it is a material, so just like when if somebody was going to go get their lips puffed up with filler or collagen, it's a similar idea. If you think that maybe the urethra is like a leaky faucet and you need to replace the washer, the idea is that you can bulk it up a little bit so that it's not so leaky. there are probably some people that are better candidates for this than others. So people that have more of a urethra that's not moving because that ligament doesn't seem to be the problem, but more just the urethra is wide open. That's probably a little bit of a better candidate for it. But there are people that they will get this done and then they'll say, okay, this seemed to work really well, but the effect maybe wore off and they don't want to have to get repeated procedures that then decide they want to do surgery, or maybe this is kind of their procedure and it works for them. About 60 to 80% of people improve, but you often need to have a repeat injection. And there can be side effects associated, even though it's a minimally invasive thing, there's no cutting involved, we just do the injection. There can be some side effects involved with it as well. There are alternate treatments, and I'm going to briefly mention this because there are, even though I tell people there really aren't medications to treat stress incontinence, that's not totally true. There are a couple medications that may increase the urethral pressure so that it will help prevent it. So vaginal estrogen can be helpful in general. Imipramine is a medication that we use for childhood bedwetting and then nighttime urinary issues. It also may increase the strength of the sphincter. So that cork that was holding the urine in, it may increase that a little bit, that strength. So it may be helpful. Duloxetine, this is kind of an important thing to know because if patients are on it, it may make them have a harder time urinating sometimes, is approved in Europe but not in the United States for stress incontinence. And then I'm going to let Dr. Morrisroe talk basically about this, but there have been people that have been kind of stemming off the idea of using a CO2 fractionated laser for vaginal atrophy or vaginal skin changes to maybe that it will treat stress incontinence too. It's a promising technology. Right now, we don't have enough real good solid data. They've tried to compare different studies and we don't have enough solid data for it, but it is a promising technology, and I'll let Dr. Morrisroe talk to you about all the ins and outs of it. I'm going to talk about this super fast because I'm pretty sure my time is up. And if not, it seems like it is. So for urge urinary incontinence, which is the involuntary loss of urine with sudden sense of urgency, so patients will tell me, they're like, but I don't want surgery. Well, guess what? You don't need surgery. So there really aren't any surgeries for this. There's one procedural type thing, but otherwise these are not surgical things. And this lady I thought was kind of true to form. And then I had a patient show me this, which I thought was really cool. There's a Charmin app that you can have on your phone that will tell you where all the bathrooms are, and they rate them debating on like their different, how clean they are or not. So you can have green toilet paper, red toilet paper, you can know where to go. And it does exist for torrents, I've tried. So you can find them all over the place, which is really, can be very helpful. If you're out and about, you might want to know. So just so you know, it's Sit or Squat by Charmin. So for overactive bladder and urge urinary incontinence, it's a lot more focused on that dome of the bladder that we were talking about. So different fluids, behavioral lifestyle changes can be big. Medications, pelvic floor physical therapy again. And then there's 2 nerve treatments that exist as well. So for behavioral and lifestyle changes, limiting fluids can actually be helpful. I had a patient just actually earlier last week who said she drank 100 ounces of water a day. She's like, I go to the bathroom all the time. And I'm like, well, that's a lot of water. She's like, I thought I had to. It's like, no, you do not have to drink 100 ounces. We do not want you to be chronically dehydrated, but drinking 4 to 6 glasses of 8 ounces of water a day is fine. For people that have a really hard time at night, getting up multiple times, we ask them to try to stop drinking a couple hours before bed, their majority of their fluids. If you have to take a sip here and there, it's fine, but trying to stop the majority of fluids before beds can help. Avoiding bladder irritants, and the 2 biggest ones, because there's a bunch, but like caffeine, and yes, all those green teas during the day are caffeine too, but coffee and alcohol are the 2 ones that are kind of the biggest, and then there's a bunch of other things that may irritate the bladder for that particular individual. Some people will try to urinate on a schedule, and the only problem I have with this is that people will say, well, if I go every 15 minutes, I don't have a problem. And which is, it's a full-time job, but also we don't want your bladder to learn to be really small. We want it to be a normal size. So we don't want you going every 10 minutes just to preventatively not leak. We'd like to come up with some other strategies. But every 2 to 3 hours, if that was kind of your routine, if you weren't going 8 hours at a time, then that can be helpful for some people. For people that get lower leg swelling, which if you're standing on your feet all day, it's sort of inevitable. If you raise your legs at the end of the day, or if you get really bad swelling and you wear compression hose, that can be helpful. Continence pads, obviously, are something that's a behavioral modification that people do. All right, 5 minutes? Okay. I'll be done way before then. And then the other thing is sometimes medications, certain ones can make you have to go a lot more. So timing of those can be helpful so that you're not taking it right before you have to be gone all day away from the house. You can take it at a time when maybe you're going to be home a little bit more. Oral medications. So there are two primary categories of this. And the reason I kind of bring this up is because in category 1, there's a bunch of different medications, and in category 2, there's only one medication, and they have their pluses and minuses. So category 1 are kind of the original medications. They can have side effects of dry eyes, dry mouth, constipation. They can make you sleepy. The extended release versions of these medications tend to cause fewer side effects than the immediate release ones. And just because one medication didn't work very well for you doesn't mean that all of them won't. They're all a little bit different. So it is possible to try out a couple different ones. We are often somewhat limited based on insurance about which ones we can prescribe and in what order, but we do try to give you the ones that are long-acting first so that you have fewest side effects. Category 2 is one medication. It's that bladder that leads the lady by her hand in all the commercials. It's a great medication. It does have some side effects, but they're not super common. So headaches and diarrhea can be side effects associated. The one that we're most worried about is that for people that have uncontrolled high blood pressure, it can raise your blood pressure a little bit more. So we try to avoid it in groups of people that have uncontrolled high blood pressure. This next slide I'm going to quickly skip over, but it's just kind of an idea that they're all different. These are all the different medications and the way that we look at them and the ways that they work. So then there's another medication because there's really 3 categories. And the third category is one you don't take by mouth, and it's Botox for the bladder. So Botox is FDA approved, and it's used to inject directly into the bladder. We do it in the office, and it has a better cure rate than the oral medications do. So whereas the oral medications, when they compared them head-to-head in a trial, were about 13% of people were cured, which is not a huge number, but people were much better. Just cure rate was only 13%. For Botox, it was up to 27%, so basically double. The problems with it are that you have to get it repeated, and the biggest rate limiter that everybody kind of shies away from that I find, and I don't know if you run into this too, is that there's a 5 to 10% risk of temporary, because Botox is not permanent, but temporary and usually very short-lived in a very small percentage of people, but temporary urinary retention. So the only way you can be a candidate for this is if you are willing to catheterize yourself if you're in that category. So it is something that is a rate limiter. For some people, they're like, no big deal. If this is going to have me a better chance of being dry, I would be happy to do it. And other people are like, absolutely not. That's a game changer. I will not do it. So it just depends on the person, but it is an option that exists, and it is approved by insurance. So there's 2 nerve treatments, and then we're done. So this one is one that's done in the office. The biggest problem with it is we use a peripheral nerve. We put a little stimulator on it. It's a time commitment. And it takes 12 weeks, 30 minutes each week. You come in, you have this placed, you sit there with a stimulator on it. It doesn't hurt. You feel a little vibration in your big toe, and that's it. And you don't usually notice a benefit. Median time is about treatment 8. So you have to be kind of signed up for it mentally to say, yeah, I'm willing to sit there and see whether or not this makes a difference. And I may be in that 60 to 80% of people that feel an improvement, but I may not. And this may be 12 weeks of my life where I just came in and had this little vibrating thing on my foot and nothing really happened with it. So you have to be kind of recognizing there's no risk associated, but you may not improve, and you're not going to know until the end. If it works for you, then the maintenance is recommended every 3 to 6 weeks to come in and get a one-time session. Not all insurance. So Medicare, interestingly enough, universally covers it. A lot of the PPOs I have a little bit of trouble with. So it is FDA approved for this and everything else, but some of the PPOs consider it experimental. And it is very expensive if it's not covered by insurance. And then the last one is clearly not what people jump to first. So this is the only surgical procedure for like overactive bladder. It's also used for urinary retention and fecal incontinence, and also some of the pelvic pain issues that people can have too. It's a sacral nerve root stimulator. This is one where people do get a marked improvement with it if they go this route, but there are some issues with it. It involves us doing a test phase, typically in the office, or it can be done in the operating room, where we see if you're even a candidate. You have to have at least a 50% improvement in symptoms to be considered a candidate for this. And then it involves putting a little implant in your back, and you have I kind of think about it like a pacemaker for your bladder. You have a little battery pack back there, and you have a remote control, and you get to control not your bladder on and off. That's a common misconception. You get to control like a stimulation that you feel that helps to modulate the bladder. And it's not, the biggest problem at this point, I think, is that it's not MRI compatible. So I don't know if you run into that, but I think they're working on that a little bit. And then that's it. So thank you guys.
There we go. Thank you, Dr. Milano. All right, so who was surprised that teenagers and college-age people had leakage? Yeah, so in my clinic, the youngest we see is 3. Typically, that's more constipation or fecal incontinence in our kids. And my oldest right now is 97, which she is a kick. She was in the clinic today. But Erin was right in talking about that a lot of people don't do pelvic floor contractions correctly. And so let's try one. Okay, I want everybody to sit up nice and posture in their chairs. Yeah, there's a lot of corrections going on now. Okay, so what I want you to think about is the muscles have 3 layers. And the first 2 layers really shut our opening, shut the urethra, shut the vaginal canal, shut the anal canal. Our deeper layer is like a sling that the organs sit in, so that more lifts our organs. So I want you to try, close the openings, lift up and in, and hold, and then let it fall. Good. Let's try that again. Close the openings, lift up and in, hold, and let it go. Yes, you can laugh while you do it. It's a good test. So 2 other thoughts. Think about where your tailbone lives, okay, right around the anal sphincter, and I want you to try to draw that forward towards your pubic bone. Okay, try that instead. Pull your tailbone towards your pubic bone, hold that, and then let it go. Good, one more time. Tailbone to pubic bone in front, and let it go. Good. Last one that some people like is, you feel those bones that you're sitting on? We call them your sits bones. I want you to think about knitting them together, okay? So draw those bones together and hold that. And then let it go. You want to be able to use the visualization that you feel like you get the best contraction with. Or if you go see a pelvic health physical therapist or have your physician test you, where they're doing a digital exam so they make sure that you're doing a close and lift versus a bear down. Bearing down is going to promote incontinence, is going to promote prolapse, and we don't want that. So how many do you think you should do a day? Don't say 200. Okay, because we have those people come in. Would you ever go to the gym and pick up a 10-pound weight and do 200 bicep curls? Never in a million years. You wouldn't be able to use that arm to reach for your coffee the next day. So what research shows is 30 to 80 repetitions a day is going to lead to strengthening. We do want those to be holds, but like Dr. Milano said, 10 seconds is really not feasible for a lot of people. You squeeze as long as you can. If you can hold 3 seconds, try for 5. You want to push it a little, but you don't want to fatigue it. If you're doing pelvic floor exercises and you're getting worse, you're either doing too many and you're fatiguing, or you shouldn't be doing them in the first place. So the one caveat to doing pelvic floor strengthening for these types of things is if you have a overactive pelvic floor, or a pelvic floor that's in spasm, that lives elevated and contracted all the time, for those people, typically exercise is not the right thing, and you need more internal manual muscle releases, and that's what a physical therapist would do. So if you try these exercises on your own at home for 6 to 8 weeks, working up to 80 repetitions a day, and you're not getting anywhere with your symptoms, coming in to see a pelvic health physical therapist to make sure that you're doing them correctly is helpful, okay? All right, so we're going to introduce our last speaker, Dr. Shelby Morris-Rowe. Dr. Morris-Rowe completed her general urology residency training at the University of Pittsburgh, then went on to complete her fellowship in female pelvic medicine and reconstructive surgery at UCLA. With this specialized training, she bridges the gap between gynecologic and urologic medicine and manages all female urologic issues, including incontinence, pelvic organ prolapse, prior failed vaginal reconstructions, complications resulting from the use of vaginal mesh, recurrent UTIs, and vaginal atrophy. She has now been in private practice in the South Bay for the past 7 years and continues to strive to help women in the South Bay regain not only better medical health, but also a better quality of life. So let's welcome our final speaker, Dr. Shelby Morse-Rowe.
Hi, I see some familiar faces. I may know some of you. I've been in practice here for 7 years, and I'm just across the street. I want to talk just to touch upon what the other speakers spoke about, a slightly different aspect of vaginal health issues, particularly in menopause, vaginal atrophy, changes that occur as we become older. And I really want to highlight in the second half of this talk, I call it a new treatment. It's not necessarily that new, but it's a treatment that pretty much no one knows about. We've had it for about 5 years here. Dr. Milano touched upon it. It's a CO2 laser treatment, much like dermatologists and cosmetic surgeons use on the face to revitalize skin on the face and neck, but we use it now on the vagina. It's been around again for 5 years. I've been using it for about 1 year. And when I bring it up to people, they have no idea this exists, and it's a really good, viable treatment for this option, and it's very, very safe. So I've kind of made it my mission this year to really get the word out about this treatment option, just so that you know it can be in your armamentarium of things we can do to treat vaginal atrophy symptoms. So what is the issue that we're talking about? Basically, I'm discussing problems with genital health that are secondary to changes that occur in a woman's body due to menopause, otherwise known as like low estrogen to the vaginal tissue, the urethral tissue. It's most commonly seen because of menopause, during menopause and after, and postmenopausal women. That's the biggest group of people who suffer from these issues. But we also see it sooner in women who undergo treatments such as breast cancer therapy or chemotherapy or radiation, or have had their ovaries removed early or just undergo early menopause. So we're seeing these types of symptoms and issues in women much younger than we ever used to. So why is this occurring? Basically, when there's low estrogen levels in the vaginal tract and genital tract, you get thinning and drying of the tissue, you get inflammation of the tissue. Again, most commonly occurs because of menopause, but for all those other conditions we mentioned as well. And low estrogen levels lead to a higher, more alkaline vaginal pH, which is unhealthy for the vagina and allows bad bacteria to overgrow and leads to vaginal infections and recurrent urinary tract infections. So what are the symptoms of vaginal atrophy? The vaginal symptoms are basically vaginal dryness, irritation, vaginal itching, increased discharge, pain or bleeding with intercourse. And in addition to affecting the vagina, these low estrogen levels can also affect the bladder or in urethra. So it can increase the chance for urinary frequency, loss of urine or incontinence, pain with urination. And of course, as we discussed with the pH changes and lack of lubrication, you can get increased risk of bladder infections or vaginal infections. There's a lot of psychological and social issues that also go along with these types of conditions. There's a significant negative impact on one's life in many reasons. Decreased libido is highly significant for people who suffer from these symptoms. Sexual life is negatively affected. Marriage and relationships are significantly affected, as well as just the general sense of self-esteem. What's the scope of this problem? About 50% of all women after menopause not only have these menopausal changes, but have these bothersome symptoms attributed to it. And equates to about 24 million women in the US right now. So vaginal atrophy is a normal part of aging. As the vaginal and genital tract tissue ages with the lack of estrogen, you will always see these changes start to occur. But it's the addition of symptoms on top of that we consider the syndrome of genitourinary syndrome of menopause. So all women after menopause and as they get older get atrophic changes. But again, if they develop symptoms that we discussed, the pain, the discomfort, pain with sex, urinary symptoms along with it, these are the patients we sometimes consider treatment for. That's a really important point that comes up a lot with my patients. Patients will say, I went through menopause 20 years ago. This doesn't relate to me. But most menopausal symptoms, such as hot flashes, go away with time. As you get 3, 4, 5, 7 years away, you no longer get those symptoms. You're past the point of menopause. But unfortunately, the GSM symptoms, vaginal atrophy symptoms, if anything, get worse with time. So the further out you get from menopause, if anything, the worse these symptoms become because those tissues have just been starved without estrogen for that much longer. So what kind of treatment options do we have? There's 3 basic categories we can lump them into. The first is lubricants and moisturizers. This is your CVS grocery store aisle pharmacy that there's about 100 products you can choose from. We also have the category of hormonal treatments, vaginal or oral. and then a vaginal laser treatment, which is the treatment I want to highlight towards the second half of this procedure. So over-the-counter treatments, number one, we've got daily moisturizers. This is treatments like Vagifem, Replens, where you apply it every day and it acts like a barrier to give the feeling of increased lubrication. In addition, we've got just topical lubricants where you really just use in the moment, like before intercourse, or if you're just feeling kind of dry and itchy, you can just apply it as needed, like KY jelly or Astroglide. Again, there's hundreds of options at the grocery store. If one irritates you, you could just try another one. They can be messy. They are just really for kind of in the moment use. But the main negative about these treatments is they don't fix the tissue. They don't regenerate the tissue. They don't change the pH of the vaginal tissue to make you less prone to get infections. They don't prevent worsening of symptoms over time. They really just improve your symptoms kind of that day while you're using it. But they do work, and they work great for a lot of women, and there's essentially no risk. They're very safe. Again, unless you had like a tissue irritation from a chemical in the lubricant, there's really no risk to using these, and that's the major benefit there, and they're simple, and they're not prescription-based. The second category of treatment are estrogen-based. You can get some improvement in vaginal and bladder symptoms with oral systemic hormone replacement therapy, but I'm not going to touch upon that topic too much. I'm going to stick to the option for local treatment to reverse these menopausal type changes with vaginal estrogens and treatments. There's different forms. Most commonly, women use creams or suppositories, estrace, Premarin, Vagifem, or even a ring called E-string. They just release or get absorbed into the tissue some local estrogen. They are tricky to use. They can be messy. They can cause local tissue irritation. You do have to use them on average, the creams and suppositories, 2 to 3 times a week, every week, and it takes between 1 to 6 months to start to notice any benefit, if you notice anything at that point. So some people use it that long and they still don't see the benefit, but it's not an overnight fix. I have lots of patients, despite telling them that, they'd stop it after 2 weeks and say it didn't do anything. You've really got to commit to many months of uses to see if you're going to get that long-term benefit. They shouldn't normally have any systemic side effects. There is the occasional patient who gets the symptoms that they would get like if they were on systemic hormone replacement therapy, pelvic pain, breast tenderness, but that's not a typical side effect. We don't consider these treatments a systemic therapy. They really are just supposed to act locally on the tissue. But the benefit is it is regenerative. It will reverse some of those vaginal atrophy symptoms. It'll build up the tissue. It'll increase natural lubrication. It can be very effective for some women. And it's been in use for absolutely decades in women, and it is generally very safe. For most women, the use of local vaginal estrogen is a very safe medication. It is a controversial topic and very personal to a lot of women because it's a hormone and it can be related to hormone-related cancers such as ovarian cancer or breast cancer, or even other medical conditions like blood clots that the use of hormones and estrogens in particular are kind of associated with. We don't have a lot of good direct studies investigating the true risks of local vaginal hormone on those risks. A lot of our data is inferred from what we know about systemic hormone replacement therapy. Again, that's the pills and the patches that women wear for like the hot flashes. So we kind of take the data from those studies and we assume that there's a theoretical similar risk with these local applications, but it should be much less because, again, we're not generally getting systemic absorption. So it's the main takeaway. A lot of women want to shy away from vaginal hormone, but it is very effective. A lot of my patients use it. I prescribe it a lot, and generally it is very safe, but it does have to be a personal decision for you and with your doctor. I mean, there's definitely a large population of patients with things like breast cancer that their oncologists just want them to stay away from any extra form of estrogen, you know, if possible, and that makes this not so great an option. There's another type of hormonal treatment for vaginal atrophy which can help as well. It's called Osphena, and it's a prescription-based hormone treatment that's an oral pill you take once a day. I find the main benefit of this treatment is for women who can't remember to use the creams or suppositories, which they're only 2-3 times a week. You can kind of forget because it's not part of your daily routine. So the most common time I prescribe this is when they just don't like the cream or the cream burns or they just keep forgetting to use it. So we'll try this daily oral pill. Conversely, I got plenty of patients who say, I'm on too many medications, I don't want any more pills, and then we start with the cream. But it works just as well, and it's a lot of the same risks. There's potential risks of hot flashes, vaginal bleeding, increase in the endometrial lining, things that can kind of occur from hormones. A lot of those side effects are just temporary. But it can also take about 3 months to start to see any benefit, so you really got to commit to it. But it's also regenerative, meaning it improves the health of the tissue. It builds the tissue back up. It increases natural lubrication. It decreases the pH of the vagina to ward off from infection. it really is very helpful for all of the symptoms we discussed at the beginning of this talk. And again, it's the best hormonal option for women who don't like the creams or want something that's just easy to remember on a daily basis. I just want to make one more comment about the use of estrogen in breast cancer comment. An interesting side note to keep in mind, the American College of Obstetrics and Gynecology put out a position about 2 years ago describing that non-hormonal approaches are really the first-line agent for women who've either had breast cancer treatment or are going through treatment. Some oncologists are still okay with the use of local hormones in these patients, but first line, where you should start first, is always the other options. The other treatment I wanted to kind of highlight, this is the third category of treatment for reversing those vaginal atrophy symptoms, is a fractional carbon dioxide laser called the Mona Lisa Touch. This is the main type that's used. I've been using it for just under a year and a half with really great results. So this is an in-office treatment for vaginal atrophy, and it's for vaginal regeneration and restoration of natural kind of vaginal function, health, and pH. Basically, a lot of the same stuff that the hormones do. The results are about equally as effective. I put them kind of on the same line with all those hormonal treatments. It's just this one doesn't have the use of any kind of hormone. Again, it's the same type of fractional carbon dioxide laser that dermatologists and cosmetic surgeons have used since the 80s for face and neck. It's the same type of treatment. They just discovered about 5 years ago, they discovered this trying to find a way to help women with breast cancer, basically with early symptoms of vaginal atrophy. If it works well to revitalize skin in the face, maybe it'll work in the vagina. And so they've been doing it here again for about 5 years with really great results. It works by delivering gentle, light energy to the vaginal tissue to basically trigger a natural healing response to occur. This brings in healthy collagen, vascularization, elastin, basically promoting good blood flow and thickening of the tissue, natural lubrication, basically, again, triggering your own body's restorative processes. It's not surgical. It's been clinically proven for many studies to have long-lasting relief. It's got overwhelmingly positive results and can work immediately. In some other people, it can take a few treatments, but in some, it works after one treatment. Minimal side effects, no significant side effects, maybe some irritation or itching. And again, it's a non-hormonal solution for people with a history of ovarian cancer, radiation, breast cancer. And for any woman, even without this history, it's a drug-free solution. There's no medication or drug associated with this. So that all of those reasons, it's very safe treatment. Again, just to highlight briefly a quick older study, one of the early studies talking about 30 menopausal women with and without breast cancer. Again, overwhelmingly positive results, immediate results in a lot of them. Improvement in vaginal dryness, pain, itching, painful intercourse, even after the first treatment, with no significant reported side effects or adverse reactions. Again, there's a mention in most studies of some labial itching for some external treatments, but very minimal, and that escalation of the improvement with each subsequent treatment. So how is it done? This is a picture of the probe that we use for the intravaginal component. Usually this is a 2-component procedure, but it doesn't have to be. We really kind of tailor it to your symptoms. This is a probe that we insert into the vagina to treat the intravaginal wall. It's about 2 centimeters in length, or less than an inch. It's very smooth and it goes in easily. I don't get patients complaining of pain with advancing this. It takes about 5 minutes in the office. We often treat the external labial tissue with a different flatter probe. That's for women with labial dryness, itching, cracking, irritation, or sometimes women can have an inflammatory skin condition down in the vulvar area called lichen sclerosus. Before this was only ever treated with frequent topical steroids, but this is another great treatment for that. So for the external treatment on the vulva and labia, we do apply a numbing cream for about 5 to 10 minutes just to help so you don't feel the little zaps from the laser. The internal laser is completely painless. You might feel a little air vibration. No preparation prior to treatment other than avoiding intercourse or creams vaginally for about 24 hours, just because the way that this laser works, it works with the water in your tissue, so we don't want it to get absorbed by the fluid on the top of the vagina. So this is a picture right here of the probe entering the vagina, and the doctor's holding a ring just to kind of help identify the markings along the probe. This is a picture of looking sideways at a woman. This ring right, I turned it off. I don't know if you can see this little ring right here. That's the opening of the vagina. Here's the uterus. And the probe right now is seated the whole length of the vagina. The laser comes out for this edge right here, like this, and we rotate the thing 360 degrees and go all the way around the sidewall of the vagina and then back it out a centimeter and do the same thing, back it out, and basically we're treating the whole length of the vagina 1 centimeter at a time. This part of the treatment takes about 30 seconds. It's really quite fast and is completely painless other than having the probe in the vagina, which is again about 2 centimeters. But the laser here, because of the way the nerves are in the vagina, you don't feel the laser at all. This is just and kind of a picture of what the laser dots look like. They're just barely bigger than microscopic. You have to look really hard to even see them on the tissue. They just look like little round dots. The depth that the laser's penetrating is incredibly small. Hence the minimal side effects most people get after these treatments. And it's these little tiny laser injuries along the vaginal mucosa that triggers that restorative process to occur. And this is just kind of just a picture showing the triggering of new blood vessels and blood vessels that bring collagen, elastin, hyaluronic acid, all to kind of build up the tissue. And I love this slide. This is a great slide. It shows a patient who was biopsied before treatment with this laser and then after 2 treatments of the laser. And what we're looking at mostly is this top layer of epithelium here, this part that looks like dark purple, not light pink. That's the top layer of the vagina, the part that you would touch if you put your finger in the vagina. And you can see compared to this one, it's very thin, it's frail, kind of flat. It's not very purple, just kind of red. This is after 2 treatments with this laser. This compared to this, it's about 4 to 6 times thicker. So this is what you're getting. We're getting increased thickness, moisture, and strength. You're getting growth of vaginal mucosa tissue, increased, again, moisture, elasticity, and that pH, when they test the pH, it generally comes down lower to a more acidic pH, a healthier pH, to help prevent infection. Now, I want to make it clear, though, we have slides very similar for women who use topical vaginal estrogen. So when we biopsy women after 6 months of use of Premarin cream or estrase cream, you can see very similar results. In general, across the board, results are about the same. We can biopsy them before and after and see significant improvement in the vaginal tissue strength of the epithelium. It's just a different way to do it. The hormones do it by getting into the DNA of the cells, really encouraging them to grow thicker, stronger. This works by natural healing, natural injury causing a healing process, but the end result's basically the same thing. Again, the main difference is one is hormone-based and this is laser-based. Recovery, there's not much recovery. There's an immediate return to activity. You can go to work, go home. You might apply topical lubricant for a day or 2 to the labia if we treat externally for some itchiness. That's the main side effect people complain of is maybe 1 to 2 days of labial itchiness for external treatments. No side effects other than maybe a slight increase in discharge for a day or 2 for the intravaginal treatment. You can resume intercourse within a couple days, but other than that, you're really not restricted for anything. Just one more quick mention of a newer study evaluating the CO2 laser on vulvovaginal atrophy in both patients with a history of breast cancer and without. Half the patients had cancer, half did not, and they did questionnaires as well as biopsies before and after for these patients. And this was a good study where they demonstrated a reduction in stress urinary incontinence, kind of like Dr. Milano alluded to, that this treatment is a treatment we are recommending for mild stress incontinence. We don't have tons of data on this, but I have personal history with patients and staff and some studies that show that this can definitely help, again, in mild cases of stress incontinence. I have patients come to me with severe stress incontinence. They're wearing 5 pads a day, and they say, oh my gosh, you can cure me with this laser, and I say no. It may help a little, and it may help your dryness, but it's not going to reverse severe leakage issues. Again, it's the woman who wears like 1 pad a day. I've had some cure rates and a few people like that. But again, for just mild stress incontinence where they just need a little thickening and support of that tissue under the urethra, I have definitely seen good improvement. As the study shows, vaginal health scores, quality of life scores, questionnaires, very much improved with treatment, less pain with intercourse. Again, no adverse events reported by patients. If anything, just some local irritation that's always temporary. And again, patients with a history of cancer or without had equally good results. Significant growth of new healthy vaginal tissue on the biopsies. And again, testing the pH before and after treatment, a return to a normal premenopausal pH of the vagina, which again should be protective against those recurrent urinary tract infections and vaginal infections. And they actually measured the width of that epithelial layer of the vagina before and after treatment. And I think on average it was, oh gosh, I keep doing the wrong thing, from 100 to 500 and fold about, 4 times, thicker that layer they biopsied. There was not one patient who didn't have a significant thickening of that layer of tissue. So in summary, problematic vaginal atrophy adversely affects up to 24 million women in the US right now. But in the treatment options, again, topical lubricants and moisturizers, in short, can be potentially effective in the moment, are very, very safe, but they don't do anything to restore good vaginal health. They are just to help kind of symptoms in the moment. Second category being vaginal hormone treatments or the oral hormone treatment. Also a very, very effective treatment, but it's hormone-based, and you have to talk to your doctor about the risks and benefits, even although negligible, still the potential risks of hormones and if that's an issue for you or not. But if it's not, it's a great option, and I treat lots of women with the hormones with good results. But then the third option, again, I just want to kind of get the word out there so that people know this exists, and we have an equally good, effective option with a laser that does not require any hormone treatment or estrogen-based way to improve these symptoms, and it's equally as effective. Again, it's safe, it's hormone-free, drug-free, very effective, it's very durable. We have data showing up to a year, people maintaining really good results. On average, women come back about once a year for one-time treatment to kind of maintain this benefit, but that can be variable from patient to patient. And again, it's quick, in office, and very effective. And I've been doing it for about 13 months, and I really love it. And I've had it, if anyone wants to know about my experience. There's lots of videos online if any of you are interested to kind of learn more about it and watch. And I have some brochures in the back with some websites and stuff you can look at too with some more information. Hello. Thank you.
Okay, so now if you guys have questions, do you want to put them in the air? I'll walk around and grab them from you, and we should have enough time to answer.
Okay, so question number 1 was what can be done about painful intercourse, vaginal dryness, etc. So again, just to summarize like the talk, there's the 3 broad categories. There's lubricants that help in the moment. There's vaginal or local treatments of estrogen, or we have CO2 laser treatments. Those are really the 3 main categories if the painful intercourse is due to atrophy and vaginal dryness. Now, painful intercourse can also be due to other things, and this is why an evaluation by one of us is helpful. You could have prolapse, a vaginal bulge. Some women have pain with intercourse and stop having intercourse because they've got the prolapse and it feels like their bladder is getting hit when they have intercourse, and that causes pain. And if that's the case, perhaps what would help the most is actually a surgery for the prolapse or a treatment for the prolapse. Some women actually get pelvic floor dysfunction and spasm, and so they tighten up, and so when they have intercourse, they get pain for those reasons, and that they can be helped really well with pelvic floor, like very successfully actually with pelvic floor therapy with Jenny. And so again, painful intercourse depends on what the etiology for it is. If it is from dryness and atrophy, just getting older tissue, menopausal changes, lubricants, local estrogen treatment, or CO2 can all be potentially very effective. Again, but an evaluation to determine if that is the reason for the painful intercourse can be really helpful. And again, does the Mona Lisa laser help with incontinence? It can help for mild cases of stress incontinence, and I've seen it help with urgency and urgent incontinence on a mild level as well. It's not as well studied as the atrophy and dryness and pain symptoms, but I've absolutely seen it be effective. I usually consider it in conjunction with other things, with physical therapy, avoidance of bladder irritants, maybe medication, but I've absolutely seen mild cases of both types of leakage improve. And does the CO2 laser work for vaginal prolapse or atrophy? It does not treat vaginal prolapse. There's actually a different type of laser that we didn't even go into tonight, which is a radio frequency laser. It uses a different type of mechanism, but a similar approach, which can actually help, again, mild cases of prolapse and laxity. It's a tightening procedure. So it's a different type of laser, a radio frequency laser with a very similar mechanism of how we do it in the office. So again, you really just need to be evaluated by a doctor who kind of knows the different treatments. It can gear what's needed towards you. I do treat both with 2 different types of lasers. And someone asked if it was covered by insurance. The laser is not covered by insurance by anyone. CO2 lasers aren't covered by insurance for, I don't think, for any medical condition anywhere in the body. And bottom half.
Yeah, this is here. Yeah, so for Botox, somebody asked me how often it needs to be repeated. So it lasts for 6 to 9 months. So typically it's done once or twice a year, and it does need to be repeated. And the maximum effect you're going to notice at about the 2-week mark. It takes about 48 hours to start working. Maximum effect is noted about the 2-week mark, which is where we usually check to make sure you're emptying all of the way. And then it lasts for about 6 to 9 months, and it just depends on the person.
Should I buy stock? It depends. Anybody want to go there? My answer would be no.
No. Yes. That question does not need to be asked. How long does the sling mesh last? So it's intended to last forever. You're not supposed to get a repeat procedure. It's supposed to be one and done. We have 20 years of data on it right now, and the subjective improvement looks pretty good for all the way out to 20 years. Is the CO2 laser, that's you. Are most of these treatments covered by insurance? So I think this kind of answers a lot of the questions. So the CO2 laser is not covered by insurance. The vast majority of the rest of these are covered to some degree. Sometimes you have to have tried other treatments first. But basically everything else we talked about tonight, depending on insurance and depending on what else you've tried, is covered by insurance. Moving on to you for a minute while I keep looking.
Okay, can restless leg syndrome be associated with small bowel prolapse? Not that I've read. Is estrase good for rectocele? So estrase is going to affect the vaginal mucosa. Rectocele is an anatomic issue. I don't know I don't think it's going to treat your rectocele. But if your rectocele is causing vaginal dryness because it's exposed, the estrase may help that vaginal tissue. Be a little, yeah, it may help with a surgery or pessary treatment for it. I'm going to keep going. If there's a question, if you had a prolapse, what are your chances of having a second prolapse? So remember when I was talking about doing the facelift and attaching it to the ligaments? So if you do that, you have a 3 to 8%, depends on what you read, 3 to 8% chance of failure within like 10 years. Sometimes higher, depends on your surgeon. So but of course, it depends on what type of procedure you have. If I'm quoting vaginally, but for most part, every procedure will last for about 10 years on average. Sacrocolpexy typically longer. Usually when you have a vaginal suspension, depending on your tissue, should be longer too in the hands of the right surgeon. One more and then I'll pass the microphone. If prolapse left untreated, what's the worst case outcome? That's a good question. So the one thing I can think of is if it kinks your urethra where you urinate from, you could end up having urine go back to your kidneys and causing kidney disease. That's probably the most major issue. Another thing is if your prolapse is exposed and it's rubbing against your underwear or any tissue, it can get excoriated. Basically, the tissue can slowly peel off and get exposed, and I guess you can have an ulceration from there to the point where, it can expose your anatomic parts. I have not seen that, but I've seen a pretty bad ulcerations. But I think the worst outcome is those two, particularly the ones where your urine builds back up and you develop a kidney disease. Oh, I'm sorry, I have one more here. I had an anterior vaginal repair, but think it's not working. Bladder still too low. I feel a lump in the vagina again. Would this require another surgery or repair of the anterior wall again? Well, it would depend. One thing would be you'd be evaluated since you're symptomatic. It sounds like either pessary or surgical management, or even physical. You could do physical therapy if you want it, because I understand a lot of people don't want to do surgery again. So you could do physical therapy, pessary, surgery, and it could be in that order.
Can I add something? That's my question.
Yes.
That's what I learned tonight is I did not have anything to help put the bladder back where it's supposed to be. So with that, since I didn't have that in the surgery, is that part of the?
She didn't have an apical repair.
Oh, you didn't have an apical?
Anterior repair and a sling.
Yeah, so that's why typically you'll see a failure sooner. I mean, even with addressing the apical defect, you could have a failure, but it tends to last a lot longer. So what you want to do is see one of the physicians, have it readdressed. But again, you can do physical. You can start with, depends with physical therapy, pessary, and/or surgical management. Of course. I'm going to keep going. Okay, what is the usual recovery time after prolapse surgery? Okay, is it covered by insurance? Yes, if you have insurance, most, if not all, prolapse surgery is covered. Number 2, recovery time. The great thing is, like I said, the true minimally invasive surgery is vaginal, in my opinion. Recovery time, patients go home the same day. I tend to, because in California, I keep my patients over for a 23-hour admission. A lot of my patients seem to be a little bit older as well. I just want to make sure they're doing okay, and they speak to me the next day. But typically, oh, no, just like so they have questions and whatnot. They don't go home wondering like, yeah. No, they all survive. One day. But it's surprising. A lot of patients can go home the same day, but I keep them usually for 23 hours, up to 2 days. But maybe Dr. Milano and them, they send them home the same day. It depends on the prolapse repair as well. If it's a major repair, I'll keep them. But if it's just like one compartment I'm addressing, like a cystocele and a suspension, I'll send them home the same day. Okay. Oh, this one's yours.
Oh, it's mine. Thanks. All right. Okay, and I would agree with that. I think most of us keep a patient overnight if we do a major prolapse repair. The nice thing is insurance might consider it outpatient, but the hospital has a 23-hour observation thing, so you can still be considered outpatient, have it covered by insurance, but stay the night in the hospital. Okay, so somebody asked if I have diverticulosis, can any of these treatments or on incontinence be coordinated or combined? And yeah, it's just a matter of coordinating with your surgeon. So we do mini surgeries and do an incontinence procedure at the same time. It's just really a matter of coordinating with your surgeon. Yeah, I think we already talked about that. Let me see if there's one more. This one I don't want to answer. This one, so why do vaginal yeast infections, do you want to answer this? Oh, okay. Why, well, I don't know. Why do vaginal yeast infections and cervical cancer occur far less frequently in older women? So cervical cancer is probably a little bit of a conversation that involves, and we didn't talk about this so much this evening, but what causes cervical cancer is a sexually transmitted infection called the human papillomavirus. Up to somewhere between 80 to 90% of people, men and women, have been exposed to this that are sexually active. Most commonly, people contract it when they're first becoming sexually active or have multiple partners. There are many things that can happen with HPV. You can either contract it and clear it, which is what happens the vast majority of the time. You can contract it and have latent HPV, which means it's there but not doing anything. And that's what we're monitoring for. Or you can contract it and it can turn into cervical changes, which, heaven forbid, turn into cervical cancer. So because of the sexually transmitted nature of the infection, it is more common to have it happen in people when they are having multiple partners or new partners. This does not mean that it doesn't occur when people are at other ages. It's more of what is the overall risk of that population and how many partners do they happen to have. So it's just more common at a certain point that people maybe have found their partner or whatever it is and maybe are not as exposed as much. And so there's a bunch of cervical cancer guidelines that go along with that. Why do vaginal yeast infections happen less frequently? So yeast infections can actually happen at any age, and it's not limited specifically to a particular age group. So I see it in people of all ages, so I'm not going to say that it's less often then. There may be something to do with a little bit of a pH issue because yeast tends to be a little bit, anyway, it may be a little bit of a pH issue, but it's still there. So people at all ages get yeast infections. Okay. So this one says, this seems like it's strictly a women's problem. How can losing so much liquid, coupled with a recommendation of decrease of drinking liquids, not contribute to dehydration? Okay, so a couple things. I don't think we're telling you not to drink fluids. I think that what is the appropriate amount that a person needs. And so a lot of it depends on body weight. And so the typical, you need to drink 8 ounces or 8 8-ounce glasses a day is really based on like a male's body weight. And so for females, you don't need as much of that often, but it doesn't mean that you don't. But we typically say 6 8-ounce glasses is sufficient.
And don't drink as much as Tom Brady.
How much does he drink?
He drinks 37 glasses a day.
must be his lucky number. Maybe not.
I want to make a comment on that last question as well. Maybe in part what this person's asking, because I get asked this all the time, is I'm incontinent of so much urine, and so if I'm not drinking, how can I not be dehydrated? Because like it's all going out on the floor. But you have to remember, the incontinence is the same urine that you would be urinating into the toilet if your bladder could just hold more normally. So you're not losing fluid that your body would otherwise have in the tissue and in your brain, all these other areas. It's just urine that your bladder should normally comfortably be holding until you get to the toilet and tell yourself to urinate. You're not losing excess water or fluid. It's just what should normally be in your bladder. Does that make sense? Because patients ask me that all the time, like I'm losing this fluid, it's making me dehydrated. But imagine back to when your bladder functioned well and you could hold it, it's just urine that you pee out. It's not going to the toilet, it's going on the floor. I don't know. That's part of it. I had a couple more questions. Someone asked about the Thermiva laser. That is one of the older models of the radio frequency laser I kind of alluded to. It's a different type of laser treatment, uses a different mechanism. It also improves vaginal lubrication and softness of tissue, but it's more for tightening. So this is a laser that you're going to use for very mild prolapse and laxity, meaning like weakness of the vaginal walls, a little bit loose, not significant prolapse like Dr. Ascari talked about, where there's a lot of sagging, but for mild tightening issues, either of the labia, externally or internally, that radio frequency laser causes like a swelling effect in the tissue and a feeling of more firmness and some tightness. And it's done very similarly with typically 3 treatments as an outpatient, in the office with annual follow-ups. But it's a different type of laser. I use the Mona Lisa CO2 laser more for just true atrophy, pain with sex, dryness. Someone who has pain with sex and dryness, I don't want to do a radio frequency laser and make them even tighter, right? Because they're already it already hurts to have intercourse, and then if I just swell the tissues and it might hurt more. So I have one group of patients that we do the CO2 to soften the tissue, increase lubrication, and help with pain, and the radio frequency laser I think of much more, again, for saggy tissues, looseness, more of a tightening effect. So they're similar yet different. They have some overlap in what they treat, but again, you really want to speak to a doctor who understands both and picks the best one for you, because not all women with these issues, it would work equally as well. Someone also asked about the Intra Rosa suppository. I'm glad someone brought this up. This is a newer treatment that I thought about putting on my slide, but it kind of falls in the same category as vaginal local estrogen therapy for the vagina. It's a steroid suppository that gets absorbed by your body, and it's daily, by the way. You have to put it in every single day, 7 days a week, in the vagina. That's an issue for people. Twice a week, it's kind of, you can kind of get around that, but when, it's difficult to do it every night. But it's a steroid that once it gets absorbed by your body, basically it turns into an estrogen. So it's like a circuitous way to get the effect of estrogen locally. I don't have much experience. I haven't had any patients who use it. The success rates, I think, are good. I think they're the same as vaginal hormones. I don't know that there's really any difference. But my issue with it is they seem to promote it like it's not estrogen, so it's so much safer. And my ethical issue with that is it's not estrogen, you're right, but it turns into an estrogen. So, the risks, I think, are the same, even though they won't say that on the packaging. But again, I don't have any patients who've used it. I'm sure there are patients where this is maybe a better option, than the vaginal hormone, or if they're just really opposed to applying directly an estrogen. But in my mind, I think of it as very similar treatments to local vaginal estrogen therapy. Someone also wants to know about homeopathic methods for restoring estrogens in the body. This is, like many homeopathic treatments, very controversial. There's not good data and studies. This is like eating soy. Like people talk about eating soy for natural sources of estrogen. It potentially can help anecdotally. If you find that it helps, you can, you should do it. There's not a lot of good data behind it. There is some arguments and some data that shows if you take a lot of exogenous estrogen type compounds, you will shut down what little production of your own body's left that you have, because they kind of fight for the receptors there. So there's potentially a backwards kind of effect of doing that. But I have no problem with my patients if they want to try some of these remedies first, but I certainly think there's no study that will show them to be equally as effective as any of the other treatments that we have. And someone asked if the Mona Lisa touch can restore sex life that was interrupted medically by medically induced menopause for treatment for endometriosis. And the answer is absolutely. Hormone use in this situation, and it just depends on that patient's discussion with like her gynecologist. Sometimes we use hormones to treat endometriosis. If it wasn't an issue for that, vaginal hormone or Mona Lisa could both probably help. Again, we're just trying to improve health of the tissue. But Mona Lisa and this endometriosis is kind of affected by hormones. So a great way to just take that out of the equation, again, is to do the CO2 laser treatment. And I have one more that someone asked about female hypospadias, which is a really rare condition. I don't know that I've ever actually treated a congenital female hypospadias. That's a condition where the urethra doesn't form fully and it kind of forms in a foreshortened open position. Basically, it means anatomically you were born with just, reasons to have incontinence and troubles with urination right from the get-go. Every person would be different. Their examination, the treatment options for that really depend on the examination findings. If it was a mild kind of opening of the vagina, wider, or the urethra wider than normal, probably all of the same treatment options are open for leakage. If it was something really severe, this patient would probably need just a reconstruction of the urethra to kind of close it off more. But it's a real specialized type of case and just really needs a specialized evaluation by a urologist or urogynecologist about the treatment. Anything else?
All right, I seem to have more of the pain and male questions. So first question, have you ever come across a prolapse or pelvic floor problem where there might be something touching or exacerbating a nerve to mimic an orgasm? More of what that makes me think of is there is a syndrome called PGAD, persistent sexual arousal disorder. And it can either come from the nerves in the sacral spine being dysfunctional for either a disc problem or some sort of spinal obstruction or hypomobility. It also can come from the pelvic floor muscles, specifically the superficial layer, a muscle called the ischiocavernosus that sits on the side of right under the pubic bones as they extend down. That muscle attaches into the clitoris, and so you get a little more pain with orgasm when that muscle is really spasming, but if it is overactive constantly, it can contribute to those symptoms as well. There is a urologist who's a sex med specialist in San Diego, Erwin Goldstein, who treats a lot of PGAD, and so he might be someone, because you guys don't see it much. Yeah. So that would be a good place to be able to go, because often it can be just pelvic floor related. So we end up doing internal muscle releases and that sort of thing with the muscles. But it could be stemming more from the spinal column. So you want a physician to be able to rule that out. For men, are there any causes of pelvic pain other than prostate issues? And so yes, we see a lot of men who've been told they have prostatitis for decades and have tried antibiotics multiple times, and it has never resolved the problem, when a lot of times the muscles are forgotten in that area. So the prostate sits right in the pelvic floor muscles. And so if it's a muscular dysfunction, the men still feel like it is prostate pain. It can be rectal pain. It can radiate into testicular or penile pain. So that typically is treated with manual work by a physical therapist. Some of it's internal rectal muscle releases. Some of it's through the abdomen, especially if the pain is becoming more testicular. We're addressing some of the nerves that come out of the upper lumbar spine, and they come up and over your hip, your iliac crest, and then dive back down to the genitals. So we do see that often, actually, in my clinic. So typically a high-tone pelvic floor would be the driver to that. What causes vaginismus, and are there any treatments other than gradually stretching the vaginal opening with dilators, which can be painful? Is there a possibility of using Botox to relax these muscles? So I'd say 70% of my personal caseload is pelvic pain. And so I do a lot of work with women who have pain with penetration. We do a lot of manual releases. We do like the dilators to help get a stretch of the muscle that's more the full circumference of the muscle, which is obviously much more closely related to penetration. The hope is once we get a muscle to not grip all the time, that it can stay relaxed and you get good long-term success. And that's typically what we see, but the treatment may take a while. It may take 6 to 12 months to retrain that muscle. And we need to find out what's driving that muscle. Why is it spasming? Are you weak in your belly and your pelvic girdle? Are you chronically constipated and bearing down on that muscle all the time so it stays in spasm? So we work on that to figure it out. But yes, I do see patients who've had Botox for pelvic floor overactivity as well that have done quite well.
Insurance doesn't cover that.
Insurance does not cover the Botox injections for that, but it does cover PT. All right. I'm an African-American woman, 60 years of age, who experiences pelvic abdominal pain from time to time, kind of like cramping. Why is that? My guess for that one is we have these ligaments called round ligaments. They go from your uterus to your abdominals. And they're about the only ligament in the body that actually have contractile fibers in them. So they can spasm, like a calf spasm. It tends to be one side or the other, not both sides at the same time. I don't see this in the research, but I tend to see clinically that it's more often with a woman who has a retroverted uterus, where the uterus sits backwards a little bit. So there's more stretch on that muscle, especially if your abdominals are weak and you cough or sneeze and there's a lot of movement of the uterus or moving from lying down to standing. It was my most common symptom all 3 of my pregnancies because I have a retroverted uterus, so I kept getting my round ligament pulled on constantly as well. That would be my guess, that is why that is happening without doing a physical exam. Anybody else with those? Yeah, there could be a ton. That's just my first thought on it. Best types, let me do the male one really quick. Does this have anything to do with the Valsalva maneuver? So a Valsalva is a bearing down, pelvic floor contractions are pulling up and in. So it's a little bit different there. And the question of a separate lecture for men because they have different equipment. They actually have the exact same pelvic floors, except that the women's superficial floor have an opening. So that we call it the bulbocavernosus in women, more bulbospongiosis in men. So the female pelvic floor isn't quite as robust as the male, but it squeezes exactly the same. Now, my males, I may say, try to lift your testicles. That's a better cue than most of my guys will go, oh yeah, I know how to do that. Right, that I know how to do. So very similar strengthening that we do, but we're also looking for constipation, any other drivers that could be causing the pelvic floor disorders, whether they're tightness issues or weakness issues. All right. We're getting, they're giving us the hook. Yes?
If we didn't answer your questions, you're welcome to come up
I only
and
have
chat
one
for a
more.
little bit,
Yeah,
but
okay.
we want to be respectful of the physician's time. So thank you all so much. I guess I should be speaking, but thank you all so much for coming, and thank you to all of our speakers this evening. So, yeah.